Welcome to Tête-à-tête Health. I am Aurundhati Parmar, Editor-in-Chief of MedCity News, and today I have with me Don Antonucci, CEO of Providence Health Plan. Welcome, Don.
Thank you for having me.
So, we're at a very interesting point. During the COVID emergency, sort of a kumbaya moment, everyone forgot all the historic animosities and got together and we survived it, although a lot of people didn't. And now we're at a point where we see real antagonism between payers and providers. A lot of it around prior authorization. Mm-hmm. So I wanted to see what you are doing at Providence to sort of smooth relationships with providers when it comes to prior authorization.
Yeah, and it has been antagonistic, and I would say part of the reason it's ramped up to the degree it has is because, as we know, providers across the country are hitting a breaking point from a financial perspective. We are in a unique position. So as Providence Health Plan, part of Providence, even though 30% of the utilization of our health plan goes through Providence, we have other partners outside of it, we are positioned a little bit stronger because we do understand the pressures, and at the end of the day, what providers would say is that they're looking to be paid fairly for the services that they provide. So a lot of what we do, because we also have prior authorization, is make sure that we're listening, really communicating with our providers. Any kind of changes that we're making sure we're doing it eyes wide open, and that has seemed to be really beneficial for us with not just Providence, but also outside of Providence. That said, payers will say, rightfully so, that there's cost pressures. Employers, for example, are paying for a lot of the cost shift from government programs, Medicaid, Medicare, over to the employer side. So at the same time, we're also on that journey as a health plan too, where we have to make sure that we're paying accurately and we're paying for things that need to be done when they should be done as well. However, I think the one difference is that we're able to kind of communicate that and stage that as we go forward.
So how can technology help smooth this? And we hear a lot about AI trying to, speed up the prior authorization process. Has that been your experience, and what kind of tools are you using?
Yeah, so we've, interestingly enough, a lot of the tools from an AI perspective have started with Providence as from a delivery system perspective. And as the health plan, we're $2.7 billion in revenue of a $27 billion Providence organization. But I'll give you an example. So one of those that came up is called Xolis, X-S-O-L-I-S. And basically what that's done, starting with the delivery system side, is helped them code and also reduce length of stay, which is an important priority, by like 30% using this AI-driven technology. And what we've done on the health plan side is we've reviewed Xolis, because they've also have a health payer application to it as well, and found as we looked at it that actually the coding for inpatient stays is really accurate. It's really well done, and it's passing all of our prior auth. So what we look to do, because a health plan also does things like concurrent review, is now it's on us to look at that and go, all right, from an administrative efficiency standpoint as a health plan, do we need people doing this concurrent review in these areas when, at the end of the day, this is all coming through and going through the system appropriately so. So that's just one example of AI that the system's using, and now the health plan's taking a look at it to make sure that we're leveraging it, to make sure that we're administratively efficient, because we don't need to be doing the same number of concurrent reviews for something that would be going through.
So there's been a lot of articles over the last couple of years about the negative effects of AI in how they're being used to deny claims. Who is looking at sort of guardrails in this arena? I mean, how are you? Obviously, prior authorization is not easy, but at least it's a clear example of, okay, we're trying to smooth the process. But whether denying certain procedures, denying certain sort of prescriptions or what have you, some of the articles from STAT and other places have pointed to how people have been just thrown off of certain normal means of care that they were getting because the algorithm determined that it's not eligible. So there are negative effects of AI. How do you balance the two?
Yeah, and I think this is where that dialogue at the end of the day, and I think we're very fortunate the position I'm in because, for example, we share a promise at Providence and Providence Health Plan. It's to know, care for, and ease the way of our members, our patients, our providers, and that's our goal. Like that is at the end of the day our goal. And I look at AI overall. I look at 5 categories. Does it improve affordability? Does it improve access in any way? Does it improve quality? Does it improve experience for both members, but also for the doctors and the nurses? And finally, does it have a health equity lens to it? So literally, our promise is our North Star. We look through those categories and are able to have that conversation. I think part of the reason you're not seeing it with the rest of the world is because there's a very specific focus that payers have in general of controlling costs. They're doing everything they can, and then you got hospitals deploying, like I just mentioned, AI to combat that.
Right.
And at the end of the day, we've got to really start to break through this because it's a huge problem. We know that the prior auth denials have gone up quite a bit, and come to a place where what's the right care, and put yourself in a position, because we all go through the healthcare system, what would you want for yourself, a family member, a friend, and what we want at the end of the day is the right care in the most affordable manner that's high quality, right? And I think that's the dialogue everybody has to get back to, because right now it's broke and all you're doing is disenfranchising yourself from consumers, members, providers, and the last thing I'll say is this is all in the context, in my opinion, of healthcare being at a breaking point. Like, it was so great to learn at the health conference today, attended some sessions as an example around AI, the great uses happening in healthcare. It can't happen soon enough in a way that makes sense because we are at a breaking point in healthcare because it's not affordable. And we also, as a nation, don't get the outcomes that we should versus other countries. An example would be maternity mortality rates. I mean, U.S. is 23.8 deaths per 100,000, and the average is something like 3.5.
Wow.
Yeah.
That is pretty shocking. I'm curious about some policy stuff too tied to prior authorization. The AMA has been very vocal about wanting like a national policy because they feel that providers have to wrestle with this prior authorization program by XYZ payer, and then they have to deal with another type of program by a different vendor, so different payer. So what do you think of a national prior authorization policy where it'll be more uniform? What are sort of the pros and cons of that?
I see a lot of pros. I don't know why we can't get to a place where if something makes sense and is evidence-based, and with how we can actually read data and different formats and all that, why can't we come to a standard that everybody would agree on? Because I think part of the problem is just what you're talking about, is different payers and different providers have different ways that they're looking at things, and the complexity and therefore the fragmentation it causes is significant, and that's part of the administrative waste. So I think getting to some type of common standard makes a lot of sense.
So I'm thinking from a perspective of integrated systems. Now, I know you accept other insurance too, but Kaiser Permanente, for instance, will only accept Kaiser plans. So do you think the problem of prior authorization reduces if you're in an integrated system and you don't have to deal with so many different
absolutely. Kaiser is a great example of just that traditional closed model where I would assume that the friction is very low in that model. I've never worked for a Kaiser health plan, but because it's simple, because they've got that agreed upon, and they're not dealing with all these different standards, I would assume it's a lot better.
Okay, so let's talk about other technology adoption, because I'm assuming that prior authorization is not the only sticking point between payers and providers. From a provider experience, what else can payers do to make their lives easier and maybe not delay care and things like that?
Yeah, I mean, so some of the ways that on the payer side for us that we're deploying AI, and these aren't groundbreaking things in terms of just clinical care or anything like that, because we're on the payer side. So one example is how we price our business. So we're using something called gradient sale, which actually for fully insured employers below 100 employees, health plans typically have to price that business, and there's not data really that's available, so you're doing it manually. So we've been able to use that. It's able to pull in data from all different sources at a member level and then aggregate it to the actual employer level, and our pricing accuracy and efficiencies have gone way up. That's one example there. The other thing is we just went to a new customer service platform called Ring Central. And there's a part of that we've plugged in with our interactive voice response system is called Amelia. And that is actually listening to conversations and conversational AI. And what we're doing, we just did this June 2nd, we implemented it, but we're learning from what are people calling in about, how are they asking about it, and then that's giving us insights. And then on the back end, we can start to change our business in terms of what customer service representative it goes to, or how do we change the IVR so that it actually meets people's needs that much sooner and faster? I mean, even outside of healthcare, we've all had experiences, I think, where something like that is working today really well. I've also just had recently an experience with a hotel chain, I won't name the hotel chain, where I was calling about a very specific question. I'm curious about how to use my points, and it couldn't answer, and it ended up hanging up on me. So like that's what we don't want to do in healthcare, but I think that's also the opportunity, and that will help us become more efficient, and at the end of the day, improves that member experience.
I mean, I totally agree with you. I mean, I still remember, 5-7 years ago, dealing with the patient portal and uploading your claims. I mean, I probably got gray trying to just type everything in. It was so annoying, and now I feel that user experience is a lot smoother, visibly so, and I'm a fairly critical person, so me saying that. And it seems like people are genuinely trying to help you, while before it was, I mean, I had a really crazy case where I was trying to get a dentist for my parents. I managed their healthcare, and I called, I won't name the pair here, but I called them, and I said, look, I can't find the people in your network. Can you please help me? So they sent me a PDF of the people in their network. I got an appointment, went over there, took my parents there, everything was fine. Then I get a bill saying that they were out of network. I'm like, are you kidding me? I just called you. And I had to fight to get like $50 back. That's all that they would give me. I think I paid like $500. But they hadn't updated their records, and it was my fault. Yeah. So I think things have gotten better since then, so I'm getting less gray, I guess. Yeah. Wanted to talk to you in general about how you work with new technology companies. There's so much disruption out there. At the same time, the thing that we constantly hear is that payers and employers do not want to deal with point solutions. And yet, platforms are not built in a day. So I'm just curious about how you look at new technology, how do you adopt new technology, what advice do you have for startups?
Yeah. The first thing I would say is it all comes back to the type of organization that you're in. So we're a health plan as part of a provider, as a parent organization. We'll be about 500,000 members, every single line of business in Oregon as a health plan, and then expanding into places like Washington and California. But we're 500,000 members. We're not going to have the scale of some of the nationals and all of that too. So as we evaluate technology, and we've got to be really smart with our resources and timing, what we're focusing on today is making sure that is the juice worth the squeeze? Has it been proven? How does it fit in with our workflow? What's the ROI? What is the return on investment? That doesn't have to be dollars. That can actually be the experience is going to improve this much, or this many people are going to engage with it. We've actually got some amazing partners out there where we've gone back and said we're getting exactly what we need. We also have some amazing partners out there that are truly amazing, where it's been on the health plan that has not been able to actually get the use of that partner in the way that we want to because of how we were operating at the time. So I think for us, as we're evaluating new technologies, we're looking in very specific domains. So for example, right now we have a huge effort at our health plan of just making sure that our claim system, customer service that I mentioned is brilliant at the basics, all of that. And we're doing a lot right now as a health plan to make sure our data is very clean. The other thing that gets lost a lot of times with AI, I think that we gloss over a bit, is garbage in, garbage out. I'm sorry, you can have the best high-running vehicle car in the world, and if you're going to put garbage, fuel into it, it's not going to run very well, right? Yep. So for us, we're really focused on that, which will be complete in 2025. That enables us to turn on some of this AI with some of our partners, or go ahead and start to very smartly partner with some of those solutions in the market. But we do want to see that they are working with others and have some success just by virtue of who we are as a health plan inside a larger, Providence.
So I wanted to ask you about that. I mean, there is a real race towards adopting AI, and it feels like, even as Siva said, in this conference, it could be called AI conference. Health is just another name for it. In that race to adopt AI, are people giving enough thought to how to do data cleaning, how to really have data governance, and how did you stop yourself from jumping into something and instead of first actually looking at how to improve the data and make sure it's accurate?
We've been very disciplined. So I would say I'm not very patient, but I've learned patience. And as soon as I'm like, hey, what about this? My CIO will say, first thing, like, we got to make sure that we have this, then we can turn it on. So for me, it's all about basically, what are we trying to accomplish it? When can we accomplish it? And how are we going to do this? What needs to really be behind it? There's a lot of things that we've moved forward in the past, or that we could have moved forward with, that just aren't going to work if you don't have really good data and an understanding of how you're going to deploy and use a partnership or a technology. So we've gotten much more disciplined, especially, I would say, I've been there 3 years, over the past 2 years, about really selecting those partners. And I think that's what you got to do. I mean, and again, we're a certain size health plan inside of a delivery system, and we want to make certain that what we do is going to have real impact in one of those categories that I talked about, and because we can't waste our time on putting something out there that's not going to work and not be efficient for us and not move the needle.
Mm-hmm. Now, in health tech, many times, I live in Silicon Valley, there are a lot of startups that create products and then realize there really isn't a real problem, but they've just built a new technology. And so physician input is really important. When you're trying to adopt technology, create technology that improves the provider experience, do you ever lean into providers within Providence to collect their feedback on what they would really like to see?
Yeah, in fact, it's almost a little bit reverse. I get to tap into this great ecosystem of so many people at Providence on the delivery system side, focused on AI, and they're doing that automatically day in and day out, and they've got their governance and the way that they're going about it, so that we've got lots of examples inside of Providence. So it's almost the reverse of when I hear about a new application or technology that we're using, I can go right to the source of the people that either developed it. We've got some of those that are spinning out and doing great things in the marketplace, and other solutions that they've partnered with. And then what I then look to do is say, how does that connect with, like Zolis I mentioned, with a health plan? How could we leverage that? Because if there's a foot in the door with Providence and it's having that impact, say, with our doctors, as an example, the first question I have is, what's a health plan's ability to connect to that? And then also, hey, I mentioned 30% of our utilization is going through Providence. Is that something some of our other provider partners out there may want to be part of and be able to use? Okay.
And then one final question from me. Earlier this year, you obviously had the Change Healthcare cybersecurity incident, and it really hurt not just patients and pharmacies, but it hurt providers too. We've heard stories of how they had to, independent practices had to take out personal lines of credit to be able to stay afloat. So as you're dealing with a plethora of data, sensitive data, how do you make sure that your data is secure? Yeah. That's a big risk now.
It's a huge risk. We spend a lot of time, and we have our own resources at the health plan on cybersecurity, and we partner very closely with our cybersecurity folks on the Providence side of things as well. And the Change Healthcare was a big deal. And the last thing I'd say is, because we're embedded in the communities and all that, like, the first thing we started to do is just really pay attention to our data, reach out to some of those providers, see if they needed any assistance or help, and then also just make sure that we were aware as a health plan, all right, how's that affecting claims and things that we have coming in. But we weathered that really well because of the attention that we've paid to cybersecurity. That said, we can't let up, because this, as we all know, I mean, it's happening across the board. It's significant. Mm-hmm. And so for us, we're constantly focused there, constantly doing training, constantly doing checks of our own systems and all of that, and then really partnering with the Providence delivery system that's focused very broadly on it as well.
I think it was a wake-up call for a lot of different organizations. Yeah. Well, I will stop there and I will open it up to questions. Please go ahead. Don't be shy.
This is probably not a popular question to ask, but as someone more on the tech side, just idealistically, like what would happen in a world with no prior auth? Like what is the downstream play it forward a couple of years? If we just got rid of prior auth, what happens? What breaks? I think today it would be pretty scary for payers because, remember prior auth is not just about cost, but it's also about is somebody getting the right care that they actually need? And so there's some real clinical aspects to prior auth. So I think the idea over time would be that could really start to go away or go away for the majority of as long as you've got, which is happening more and more now, systems between payers and providers talking to each other so we can get out of sort of the war on prior auth and get to a place where, again, back to that focus, is this the right care, the most effective, and so there's some aspects of prior auth that actually protect people, right? So I don't think we're there yet today. That said, with what I'm seeing with AI, and these things take time to go forward, that could be, a place that we do get to at some point. But I think we're still a ways away from that.
Follow-on question: is there a role for gold carding of providers as United Healthcare has started to do?
Yes, yeah, and that's something. It's funny to hear these terms because, boy, I think I was talking about that in 2015 and 16. I was in Washington State with a plan, and yes, I mean we should be doing that, and AI should really start to facilitate some of this as well, right? Yeah.
Why the policies cannot be standardized at the national level. I agree with you that policies are so different, right? But what about from a provider perspective and also from the health plan perspective? It's around innovation, access, and quality. Because, for example, if you think about, I can give a very simple example, right? Like the ECGs, right? I hear from a cardiologist, right? They say that between CTI and ECG, like CTIs are very cost-effective and more accurate. But still, in many places, people use like ECG. That's because it's not available. So if you try to standardize on policy, are you going to have a single payer system eventually? Meaning it's standard, but the quality varies from Mayo Clinic to somebody else in some other remote place, right? They don't have access to it.
So I hear what you're saying, and I think, because healthcare is local, right? And it depends. Yeah. I mean, rural communities are going to be different than, and people have different. So I think, while maybe you can't flip a switch and have, there's a bunch of things that I think we can come to an agreement on that should be standard. And again, I keep looking at the technology. We should be able to even differentiate, and start to do that more and more at a local level. So, when you think about it at a rudimentary level, Oregon's been leaders. I'm going to talk a little bit about this coming up as well. Leaders in really innovation with Medicaid in Oregon as an example. And the power of it was really a prioritized list of what do people get care for and keeping it locally with what was called these coordinated care organizations as well. But there's a standard, sort of prioritized list for Medicaid in Oregon that everybody was kind of working towards. So I think there's a way to do both, but the other thing I'd say is you got to start somewhere.
Thank you so much, Don, for indulging us. I had a lovely, lovely conversation.